Good morning. We're getting everyone in from the waiting room. Everyone will be have their microphones muted for this presentation, but we still want it to be very interactive and engaging for you. So don't forget to use the chat. I will be monitoring that chat for any questions or comments that come up. And we will likely have some time at the end too, where you can ask your questions. So feel free to do that. And of course, always feel free to use your reaction emojis. If something is said that resonates with you, or to show support for something that someone else has said, that's the beauty of having our Zoom presentations, is we're still a community and we can connect and support each other. We're going to go ahead and get started, but I will keep watching the waiting room. Welcome. I recognize several faces on here, and there's some new faces too, which I always love seeing. I am Tanya Hitchman, the Director of Community Programs for ALS Texas. And again, I've seen many of you, and I'm glad to see some faces I haven't seen before. These conversations that we have, such as this, are never easy, but ALS Texas and really all of our partners at the clinics throughout the state want to have the tough conversations, because those are part of supporting our community. We want you to have as much information as you can to make the most informed decisions that are best for you as an individual and for your family. And that's different for every family, but we want you to have the information. So welcome. It's so good to see you all. We are recording today's presentation, and I am going to be quiet after I introduce our fabulous guest presenter and facilitator today, Rebecca Axline. Rebecca, I'll let her tell about herself because she can do that best, but she is she does so many things for the clinic that we have in Houston Methodist Clinic, with Dr. Appel and his team. And so I'll let her talk, but I'm so glad that she was able to fit this into her schedule and to share her immense wisdom and knowledge in this area. And above all that, her passion in this area and informing families. Rebecca, thanks so much for being here today.
Thank you so much, Tanya. Good to see you all. And I'm going to put my glasses on so I can read my notes. As Tanya was lovingly introducing me, I've been with the Houston Methodist ALS Clinic for the last 16 years, and been in social work a little longer than that, close to 40. But here we have an outpatient neurology department with 2 social workers, and we cover a lot of different doctors and patients, including dementia and stroke and a lot of different neuromuscular diseases. But today I'm representing the ALS team, and I so appreciate you allowing me to talk about this, as Tanya mentioned, difficult conversation today. While I realize this can be a difficult topic to listen to for so many, I also think that it's so important to use it as a tool to learn and educate yourself and your loved ones. Whether or not any of hospice or palliative care is in your future, it's really important to have that information. So I think to talk about both hospice and palliative care, which can be confusing, I'm going to try to make it as simple as possible, but it is a complex type of care product. So oftentimes we shy away from learning what we don't know. Why do we shy away? Because we don't already know about it. It's the unknown. But when we do that, we miss the opportunity to educate ourselves about things that actually might help us. You know, information gives us power, the power to choose. Without that information, we may not understand what hospice and palliative care is. We need to also understand what it's not. Excuse me a second. The information is also important because if you inform your treatment team of your wishes, we want to honor and follow those wishes, whether no matter what they are. Dr. Appel says we start from where the person is, and we honor your decisions in your life. And so without the information, you may not know what to ask, what to have a conversation with your treatment team about, and also how to talk to your family. But this is a difficult topic, so I applaud you for being here. And as I said, I'm going to talk about it as clearly and concisely as I can. because it is one of those types of care modalities that is changing. And part of the reason it changes is because the way insurance covers it. I hate to say that, but we all know that's a fact of life. So as we talk about this, please feel free to ask or ask me to clarify information so I can be as concise as possible. So today our topic is about palliative care and hospice care, and specifically how it pertains to someone living with ALS or one of the motor neuron subsidiaries like PLS or PMA. So let's start with, again, what palliative care is. Palliative care, and I don't want to read slides, but I also want to be really concise with the terminology, because many people get both these type of modalities confused. So palliative care focuses on the relief from physical suffering. Person may or may not be considered what we call terminally ill. So the way that it's kind of discussed by people in palliative care is it's a big umbrella term. Palliative care is symptom management, and it can be from the time you're born to the time you die or anywhere in between. Palliative care addresses the physical, mental, social, and spiritual well-being. And it can be all the way from diagnosis to possibly even cure. So let's say someone has a breast cancer that ends up going into remission. It can be from the time of diagnosis to that remission, and actually all the way unless they consider it cured. With palliative care, life-prolonging medications are part of the treatment. You often hear, and again, I'm just using the example of cancer, that people are told on certain, if they're on hospice care, they can no longer be getting chemotherapy. With palliative care, the chemotherapy, life-prolonging medications continue. Palliative care also uses a big multidisciplinary approach. So palliative care can include physical therapy, occupational therapy, speech, all the different kinds of modalities that you think of. And for the most part, at least in the past, palliative care has been seen in the medical or hospital setting. So you may be in a hospital that has a palliative care physician, or a palliative care treatment team that includes physician, a nurse practitioner, perhaps a social worker, other people involved in it. But predominantly, palliative care has been in the past, as I said, seen in the hospital setting. That is changing now. Hospice care is under the umbrella of palliative care, and it's specifically for individuals with a diagnosis of what we consider a terminal disease. And that's a tough term to even hear, but terminal disease means something that doesn't have a cure. Now, many times in the past, hospice agencies requested a physician to say, this disease, this person is not going to live longer than 6 months. And without that criteria, they weren't willing to allow someone to receive hospice care. That's pretty much gone by the wayside, because most hospice agencies use criteria to establish eligibility. And we'll talk a little bit about that in the future. But when you hear, oh, the doctor has to say, I have 6 months or less, you hear that less and less. And one of the reasons you hear that less and less is doctors have stepped up and said, we can't say that they're 6 months or less. Now, let me step back philosophically in the history of palliative care. When palliative care or hospice care as a modality was started in England with the Sisters of Mercy, there were institutions, buildings, hospice homes that were built where people would live 3 to 5 years, whatever length of time in there. When hospice as a concept was then transitioned to the United States and to other countries, that's when insurance started getting involved. And I'm just going to be real pragmatic with you. I'm not the pure expert, and there may be differing opinions, but my understanding was that when insurances and Medicare became involved with hospice care, that's when the criteria of 6 months or less, or the criteria of eligibility started making into play, because Medicare wanted to know there was a certain length of time that they were going to pay for the service. So if I wanted to be on hospice care for 5 years, Medicare may not want to necessarily pay for 5 years. So there had to be other criteria, other reasons that they were negotiating the time they were going to pay for that service. Pragmatic, yes. Not, doesn't feel very good, no, but it's important to understand the history of that. Now, what hospice care does is it addresses comfort measures and prepares for the end of life when there are certain things about your treatment for the illness that you no longer want to pursue. So again, using the concept of cancer, let's say I have a cancer that I've done chemotherapy for, I've done radiation for, and it's still progressing, and I've made the decision that I no longer want to be active in that chemotherapy. My goals of care, which we'll talk about in a little bit, have transitioned to be more of comfort. Then I may say, I want to be on hospice care because I'm no longer going to receive the chemotherapy that I've been receiving. I'm no longer actively treating the cancer. That's what they talk about in terms of hospice care. So when it talks about the use of life-prolonging medications, that might include chemotherapy, that might include medications for the heart, if you were a congestive heart failure patient, something like that. And hospice care, the way it's set up right now, can be offered at the home. It can be offered in a residential facility or an inpatient hospice unit, or even as what we call virtual hospice in a hospital setting. For example, I get to the hospital, I want to go home on hospice, but my physical ability, I'm unstable. So instead of going home on hospice, they create the hospice environment and the hospice treatment in the hospital setting. That might be confusing to folks, but for example, let's say I'm in a hospital and I'm having pain, but I'm too unstable. My medical situation is too unstable to transition in an ambulance and go home again. They may bring in a hospice team to then bring medications that are going to provide me comfort. And so I have virtual hospice in the hospital setting. Makes sense? Probably not, but that's the best way I can explain it. Now, the other thing to remember is that there's also agencies that are now offering both palliative and hospice care. And that's when I was meaning a few slides ago with palliative care used to be only in the hospital setting, but now we see it more in the community. And so many times I've heard families say, I don't want hospice care, I want palliative care. So I want you to understand what you're asking for, if that's something you're asking for. But some organizations will do both, but they look differently. And that's what I want to explain to you today. So the difference in coverages, and I know this is really black and white, but I think it's important for you to know. Palliative care is covered under Medicare A and B or your private insurance to include the physician, a nurse practitioner, a nurse in your home setting. So let's say I'm in my home, I don't need to be hospitalized, but I want palliative care to come in my home. We used to call it visiting physicians or house calls, but now they can actually provide palliative care where a physician provides that attending physician treatment and you don't have to leave your home. They can provide care for you in the home, and they bill that under Medicare B or your private insurance. But let's just keep it with Medicare right now. All the other parts of Medicare B remain unchanged. So that means you can still go to any other doctor that you want to. That means you can still come back to your treatment team with ALS and still see everyone on that and bill Medicare for it. Means that you still can get home health care with a physical therapist or occupational therapist in the home. May mean that you can get medications through your Medicare as well. When you have hospice care, what The analogy I often use, and I don't think it's the best, but it's the only one I have at this point. Let's say you go to a restaurant that has an a la carte menu. You pay for the steak, you pay for the vegetables, you pay for the potato, everything is separate. That's kind of what palliative care does. You pay, your insurance pays for the physician or the nurse practitioner, whoever, to see you. They pay for your home health care, they pay for your medications, they pay for everything a la carte, coming back to the hospital to see somebody, to the clinic. When you go to hospice care, Medicare or your insurance gives a pocket of money to that agency, that hospice agency, and now they become an all-inclusive or a all-inclusive restaurant or an all-inclusive place. Everything that Medicare no longer pays for, everything a la carte. So what's confusing to people is when they go on hospice care, they go, what do you mean I can't come back and see my ALS team? Well, your ALS team still is there to provide care for you, but Medicare will no longer pay for you to come and see the treatment team. They are paying for you to have the hospice care and for the hospice team to represent you and to provide all your needs. So we'll talk a little bit about that again, but it's kind of confusing. So with palliative care specifics, you have a connection with the ALS team, and Medicare B visits are still covered, okay? So everything kind of stays the same, but what you're missing is that the personal care that many of our families say, I think I might want hospice care because then I can get more care for my husband or my wife. I can have more caregivers come out. They'll come out every day of the week. They're still not providing 24/7 care, but they're paying for that care more frequently. That doesn't happen with palliative care. With palliative care, what you get is the physician response, you get the medication management, but you still have to pay out of pocket for any personal caregivers that you have. Now, you still can use home health, but as you know, that's a limited amount. Maybe they come out twice a week to give you a bath. With most hospice agencies, they'll send somebody out at least 5 days a week to provide at least hands-on personal care, whether it's grooming, whether it's making small meals, whatever it is. Hospice agencies also have volunteers on service where they can come out and maybe stay with your loved one when you have to run to the grocery store, run for an errand. That personal care is not provided under palliative care. And an attending physician or nurse practitioner provides the house call visits. So it's a little bit more of that. It's just one more treatment that's available to you, but it doesn't take the place of everything that you've had before. With hospice, you still have connection with the ALS team, and that's what I try to remind folks. You may not all be at the Houston clinic, you may be at San Antonio or other places in Texas, but that doesn't mean you can't still reach out to the ALS team. I need to talk, I need some help. But what you're not going to get is the ALS team providing physician visits to you. You're not going to be having the nurse be able to order medications for you. You will have to do that through the hospice team. We can recommend, we can still be available, but the hospice team has now become your attending physician. Now, just as an aside to make this a little bit more confusing, if there's physicians that you see that are not related to your ALS, you can still go to see them, even if you're under hospice. So let's say I'm under hospice for my ALS, but I still have podiatry appointments because I'm a diabetic. Medicare will still pay for that because it's not connected to the ALS diagnosis that you're under hospice for. Okay? Confusing? Yes. I'm trying to be as real simplistic as I can. With hospices, what I've also found in the last 16 years is that not every hospice agency will cover the Trilogy AVAPS machine. And many of you may be on a regular AVAPS, but many of our families, our patients are on the higher level of what they call a Trilogy. They're using it as a non-invasive ventilation, but it's still a little bit more expensive than the old-fashioned BiPAP or AVAPS. And so what I've tried to do, at least for my families, is I will contact hospice agencies and find out which ones will pay for the Trilogy machine. And it's usually a case-by-case basis. I don't know specifically the cost factor, but I'll give you an example. Let's say the ordinary AVAPS machine costs $5, $10 a day to rent. The Trilogy machine may cost $50 or $75 to rent. There's a cost difference, and every hospice agency, as I mentioned before, Medicare says, we'll give you $400 a day to take care of this patient. I'm making up figures, but let's say hospice says we'll give you $400. Out of that $400, they need to provide their nursing care, they need to provide the caregivers, they need to provide rental for the Trilogy machine, they need to pay for that hospital bed that they've got you or any other equipment that they're now renting. So that's all, they're paying for everything. And that's when the Trilogy can be an issue. But we've had wonderful hospice agencies that have been willing to pay for that Trilogy because they know it's the right thing to do. The last thing somebody wants to do is to be on a machine and now we say, no, you can't have that machine any longer. You need to have a different machine that we want to pay for. You know, it's kind of like if you've been riding around in a Mercedes, all of a sudden they said, well, we're not going to pay for the Mercedes anymore. Now you can drive in the Volkswagen. I'm being facetious a little bit, but that's what I'm talking about with the hospice agencies. Usually the attending physician for your particular case, once you're on hospice care, is the hospice physician. And they are wonderful, wonderful palliative care trained physicians that work for hospice. Sometimes in our clinic, we've actually asked for our neurologists to be the attending physicians, but most of the time they don't want to be, because you want that attending physician under hospice to be able to order medications for you, to do it in a timely fashion, to be available to you on a drop of on a call basis. And most of the neurologists are not able to do that. One of the greatest gifts, I think, of hospice agencies is that they provide on-call service. So if any of you have received home health services, you know the home health agency is great, but they're not on call at 11 o'clock at night. If you have an issue, you have to wait till the next morning. With a hospice agency, if you're having some respiratory issues at 11 o'clock at night or 2 a.m., and your loved one says, I don't know, should we go to the emergency room? Should we call 911? What should we do? What you can do is you can call the on-call service for that hospice agency, and that they will have a nurse or another practitioner who can talk to you about what to do, what not to do. They can send someone out to make a home visit. They will help you manage that system at the time. So many family members who have been on hospice care said it's a greatest gift, because my greatest agony is, what if I don't do the right thing? What if I wait too long to take her to the emergency room? What if we decide to stay home? What if I go too soon and I end up in the emergency room and then they do treatment that she didn't want to have? What if? In this case, you have one more person that you can call. You can call that hospice agency. And most people have some kind of medications that the hospice agency gives you to leave at your home. So if you need to give some medications at the home, they can talk you through that as well. If things get in a critical situation and you're still not sure you want to go to the emergency room, you don't want necessarily a higher level of treatment, they do have inpatient beds located. Sometimes they're actually inpatient hospice units. Sometimes they are beds that are available, so that if you don't want to stay at home, they can talk to you about transitioning to their inpatient unit. If you want to stay at home, they can provide 24/7 care in the home for a short period of time. That may be days. It may be a certain period of time just to get through a crisis. So let me give you an example. I'm at home, I'm on hospice. I start getting some upper respiratory issues that are going on, but I don't want to go to the emergency room. I don't want to be hospitalized. I don't want to be intubated. I don't want those things to happen. We can call the hospice agency and they can send an aide or nurse out and to stay with me and the family for 24/7 for 3 or 4 days until one way or the other, everything resolves. That may mean that I get better. That may mean that death happens, but they can provide that support during that time. And they also can support the family. They can provide that support for the family as they're trying to figure out how best to love you and treat you. And they can provide, whether it's chaplaincy services or volunteer services or whatever that's needed, they can be there for that. So that to me is the greatest gift. And I'm over 16 years, I've talked to many of our families who are living with ALS. And one of the things they always want to know is, when is it the right time or the wrong time to think about this? Should I think about this? And so that's why I think it's really important to talk about it. And these are really difficult things, because let's just stop for a minute and take a deep breath. These are really hard things to think about. Is that every time you think about these conversations and these parts of life that in our culture we don't talk about death, and yet every one of us is going to leave this earth at some point, but it's not a comfortable thing to talk about. Pastor Bill is one of our ALS patients living with ALS, who's been in our clinic for, I want to say, about 13 years, maybe longer than that. But he always gives me the HIPAA permission to talk about him and to talk about his philosophy. The last sermon he gave before he retired from being a Lutheran minister, he stood up in the pulpit and said, "Life is terminal, folks. Get over it." And we can chuckle with that, and yet it's so important to understand that even though these are difficult things to talk about, if we don't talk about it, it's still going to happen. We're just not going to have any control over our choices about it. So that's why I think this information is so important, because if you never want to do this, then you don't have to be on hospice care. But if it's something that you want, it's important to know what it is and what it's not. Some of our normal responses to loss are the loss of change or plan or dreams. You've all been living this since your diagnosis with ALS. The changes in roles, as a husband or wife, or father and child. The loss of feeling protected or safe. Maybe, I can't imagine you haven't had changes in your finances or your communication. People living with ALS tell me all the time that they used to feel so independent, and now they feel like they have to depend on their loved one for everything. Fatigue of caregivers, fatigue for both of you. What I call disenfranchised grief. And what does that mean? I've heard many spouses and loved ones say to me, "I'm grieving too, but I can't ever let myself think about myself and my own grief because I don't have ALS. How selfish of me. I'm not living with this disease." And yet they are. As you probably sitting there living with ALS would say, my loved ones are living with this. They're living every day, day to day. So grief is really important. And, also, do you think because we're talking about hospice or palliative care, does that mean I'm giving up? That's a hard one to think about, isn't it? Yeah. Again, it's a choice. Life and death are going to happen to all of us, whether we choose it or not. And so giving up is not really in the equation. That gives the illusion that you and I have power over our own destiny. And we have power over our choices. But whether life happens or death happens, unfortunately, we're not going to be able to choose that. What you can choose is how you want to be honored and how you want the last days on this earth to be. And that's where the comfort and the goals of care, I think, are really important to talk about. Agencies differ in their expertise. There are some hospice agencies that know ALS. They know what you need when you're starting to get anxious because it's air hunger. They know that's how to treat that. They know how to contact the team when they feel more information, they need more information. It's important to know that Medicare and other insurances cover hospice at 100%. There's no out-of-pocket cost for that. It's important to know the criteria for hospice. I mentioned at the beginning that they used to ask the doctors to say, is it 6 months or less? Now they look at the particular facts of the criteria. They look at your respiratory status. And you guys know this because you do it all the time. They look at your MIPS and your MEPS. When you have your pulmonary function tests, they look how those are. They look about, are you losing weight? Are you gaining weight? I remember working with an individual with ALS many years ago who initially lost a lot of weight. He decided to go on hospice care, but he had also had a peg because, again, on hospice care doesn't necessarily mean you can't have a feeding tube. And so he started gaining weight. And he was so proud of the fact that hospice kicked him out. He was kicked out of hospice because he was gaining weight. And he lived for a good long time. And then he eventually went back on hospice care, and that helped support his family and him at the end of his life. But there isn't you go through the hospice door and it closes behind you and you can't go back. People can discharge of hospice if they go on hospice care and say, oh, I thought I was ready, but I'm not quite ready for that. They look at your level of functioning. They look at those scores about how you're doing with your different functioning. And that's how they establish whether hospice is an appropriate role in your life or not. So I think it's important to understand that and know that your emotional ups and downs are part of the whole process. And whether you're talking about hospice or not, or palliative care, I'm just going to tell you my bias. I think many people will say, well, I don't want hospice care, but I want palliative care, because it's a different term. It's a different name, and it doesn't seem as scary because it hasn't been around as long. I kind of blame doctors for making hospice such a scary word, because for many, many years, and I'm talking 20, 30 years ago, hospice was only brought into the picture when it was days or hours before a person was about to die. And so you never had the benefit of being on hospice for months. We had an individual living with ALS who had hospice care for the last 2 years of his life. 2 years, okay? That's not 2 days, that's 2 years. My own mother, who did not have ALS, but she was on hospice care for 6 months. It allowed time to establish relationships with the hospice team. You got to know your caregivers, you got to know your nurses, and they got to know you. And many families have said to me, the greatest gift that I gave my loved one and that she gave me was having hospice care those last few days. Because instead of it being chaotic and full of sirens and calling 911 and having police arrive, and doing all those things at the last moment when death happened, I was able to have a quiet moment with my family. We were able to say to the nurse, we want to wait for a little while. We want to just stay here. We want to stay. And they were able to have a quiet, calm, peaceful, sometimes prayers were written, sometimes songs were sung. It was just much more peaceful and loving and graceful. And that's what I think hospice and palliative care can do for folks, and folks living with ALS and living with all kinds of medical issues. But if you don't know about it, it becomes a scary thing that you push away because it feels like I'm giving up and it feels like I'm ready to die. No, it feels like I want my life to be calm and I want my life to be graceful and I want it to mean something. And so I think coping is part of what we talk about in terms of grief and loss. And I don't see it as an event. It's not like one day, okay, I've got it. Now I'm ready. Now I'm ready. I've coped. I'm accepting death. It's a process. There's all kinds of days that you'll feel like I got this, and another days like I'm scared, or I don't know what this means, or I second guess. You know, many of our families, many of our individuals living with ALS have some changes in cognition. That doesn't mean that they have dementia, but it has some changes in how they make decisions. That really high level of making decisions quickly and easily becomes more difficult for them. So whereas your loved one might have said at the get-go, I'm never going to go on a ventilator. I don't want that. I don't want that. And now they're like, well, I don't know. I don't know. It doesn't necessarily mean they change their mind. It may be that they have difficulty making decisions, or it may be that they have changed their mind. Maybe they're afraid that family and friends may not understand if they want to go this path. I've met individuals who from the day they were diagnosed already know what they want and don't want, and other people who change their mind periodically as things go on. It's all normal. That's how we are as humans. It's important to ask questions and to know that we're not perfect, but we can together figure out what the best way is for all of you. Because, this sounds kind of weird, but wellness and disease can coexist. And what do I mean by that? Wellness to me encompasses spiritual wellness, mental wellness, well-being, all those kinds of things. It doesn't necessarily mean that has to go away just because you have a disease like ALS, that unfortunately there is no cure. We're working on it, but there is no cure.
Rebecca,
I also learned many years ago.
I'm so sorry. We do have a question, and I wanted to bring it up because I am notorious for forgetting to do that if I don't do it right when it comes up.
Please go ahead.
So the question is there a list of hospice agencies in Texas that are familiar with the needs of ALS patients?
Okay. I have a list in the greater Houston area. I don't know if the list encompasses the whole of Texas area. What I found is that just like home health agencies do, they change over time. So let's say there's a hospice agency that has had nurses on staff and really understands ALS, or physicians on staff. And let's say the physician retires, and all of a sudden the newer people they bring on board don't know ALS as well. I've had other ones who really, what I do know is that certain agencies specialize in areas. So we have an agency in the greater Houston area that works a lot specifically with people with dementia, and they know how to work with those type of families. There are other ones that have taken care of our loved ones with ALS, and they know them better. But I think I can give you a list, but I think individually you also need to do your due diligence, just like you do with physicians. You came to find your ALS physician because you asked around and you researched and you figured out what worked for you. So I can give you, Tanya and I could probably work with a list in the greater Houston area. I would lean on the folks in the other areas, Dallas, Austin, San Antonio, to see who they recommend. This is what I do for the families that I work with. If they say, I want to think about those programs, then I look at their particular needs. Are they on Trilogy, or are they on an AVAPS? Do they want to stay at home, or do they want to think about going into a facility when death happens? There are some people who don't want to die at home. And then there are some people who are adamant that they want to die at home. So I look at all those individual unique pieces, and then I reach out to a few hospice agencies. And so I give them a list, but I give them a short list of maybe 2 or 3 rather than 16, because I think that's what you rely on your team to do, is help you marry together. And so that's kind of what I do. And so I try to give people, let's say if you lived in a small town in a rural area, you may have a different agency than if you lived in a metropolitan area. Does that answer the question, I think, a little bit?
And I put in the chat, thank you, Rebecca. That is very helpful. And of course, you can always reach out to any of us, Rebecca, any of us after this presentation. But for all of you, since we have friends living with ALS throughout the state, reach out to your local care services manager or coordinator, whether that's Jennifer or Serena, Linda, Jordan, whoever you're in contact with for your personal journey. Reach out to them, because all of us do have local, regional referrals that we received from families that said, hey, we found a good experience with this agency or with this home health, whatever it may be. But as Rebecca mentioned, always vet those personally. to make sure that they're going to be the right choice for you and your family. So take it as one piece of the puzzle, but then do your due diligence and really asking those questions, like Rebecca said.
Yeah. A couple of things I wanted to touch base though as well is, since you brought up that whole idea of which agencies, I mentioned this before about the difference between a quiet, calm, peaceful death versus sirens or calling 911 and having all those different kinds of behaviors. One of the things that I also mentioned to our families is think about having the conversation, not just with your treatment team, but also with your family. I can't tell you how painful it is when I have someone who is wanting to make a end of life decision, and they've talked to their spouse about it, or maybe they talked to one of their children about it, but they haven't talked to all the children about it. And you'll have another child that'll come up, well, mom never told me this, or dad never told me this. And so what you wanted to be a wonderful, warm, peaceful time with your family ends up to be a very uncomfortable conversation with people angry at each other. You're not really angry. I'm not mad at my brother because I didn't know about what my dad wanted, but I'm angry at him because I'm grieving, and it brings all the emotions rawly to the surface. I think those are conversations that are really difficult for families to have. And I use the analogy of a frame. It's kind of hokey, but it's picture frame. If you think about framing a conversation, so when your family's home, and not necessarily for a holiday, but let's say you get on the conversation with your family and you go, I just want to talk about this for 5 or 10 minutes. And if you'll listen to me, then we're going to go have lunch together. So you frame the conversation, because I don't know if you're like me, when you start a conversation like this, everybody kind of gets sad and hokey and nobody wants to do everything. And then nobody knows how to end the conversation because everybody's all of a sudden crying and you're in this really sad mood. Well, that was no fun. Why are we doing this? So if you frame the conversation and say, I know these are really hard things to think about and talk about, but I want you to know mom and I have discussed this, and I don't want to be intubated. I don't want to be on a ventilator. So when it gets close to that time, we're going to go on hospice care, and I want you all to support each other because I know this is going to be really hard, but these are my wishes and this is what I want. That so much releases everyone from feeling that nobody knows what to do. It really guides the conversation because we all want to honor what our loved one wants. We want to do the right thing, but sometimes we don't know what the right thing is. And maybe you do want to be on a ventilator. Maybe you do want to be intubated and to live with a ventilator. We have patients we have individuals living with ALS who are that way. The hardest thing for me to see is for them to be deer that they don't understand how expensive that is, because once you're on a ventilator, you can no longer be left alone. And so your loved one either has to be at your side 24/7 or has to spend money to pay for that care. And that's the biggest thing that I think families get a deer in the headlight kind of look about, not because it's not good care. Other people say that's not how I define quality of care. I don't want to be doing that. So I think it's a personal decision. If people don't get hospice care on board, the other thing that I talk to many of our families about doing is what I call an out of hospital DNR. And I'll just talk about this really briefly. I don't have a slide, but if you don't mind, Tanya, I'll throw it in. In Texas, every state is different with how they deal with end of life paperwork. So we all heard about medical power of attorney, meaning if I can't make a decision about my own care, someone else is going to make it for me. We've all heard about advance directives, or the 5 wishes, or the living will that say, I want this, I don't want this. This is what I want, don't want. But in some states, you fill out a form for advance directives, and it's good in the hospital and it's good out of the hospital. In Texas, I will have family members say, well, we did our advance directives and I gave you a copy. And I'll say, that's great, but that's great when you're in a hospital setting. That doesn't work for when you're in your home. And this is kind of something people don't always understand. If I'm in my home at 11 o'clock at night and I call 911 and I don't have an out of hospital do not resuscitate order in paperwork, they have to do by law whatever it takes to keep me alive. That paramedic comes in the home and you say, she didn't want this, she didn't want this, and they'll say, I'm sorry, sir, but by law, I have to do everything. The out of hospital do not resuscitate form, which I can send to Tanya to have a copy if anybody wants it, is simply a form that's signed by the person that's instituting the patient or by their representative if they can no longer sign. And it's signed by the physician and it's witnessed by 2 individuals. And then you keep a copy of that form in your home. And if you call 911 at midnight and you say, I have an out of hospital DNR, they look at it and they can still provide the support in the home, but they don't have to do things that you don't want them to do to prolong life. So to me, it gives you the power, because if you change your mind and say, I want them to do everything, you just don't tell them you have the form. But if you want them not to do the things that they would normally do to keep you alive, you could say, I have this form. So those are things that we have a discussion. If you're on hospice care, they automatically do those forms. One of the worst days of my, not worst days, one a very difficult day of my life working with patients, I was asked to go by a person's home on my way to give them the out of hospital DNR because they hadn't signed the form. They hadn't gotten the form signed, and they were going to have a meeting with the hospice agency, but they weren't going to do that to the next day because they had family visiting. I got to the house and the patient had passed. And it was so sad because that happened before they were on hospice and before they had the out of hospital DNR, we had to call the police. The police department had to come out, in this case it was a sheriff, and do a full investigation. And, you know, everything turned out okay. There was nothing wrong. Nobody did anything illegal. But can you imagine at that time when you need to be grieving and be with your loved one to have to call the police and have all those kinds of things happen? So I always encourage people, even if you're not sure what you want at the end, fill out that form and have it available so you have the power to make a choice. Otherwise, that choice is taken away from you. So that's briefly what I wanted to say about that form. The other thing I wanted to mention is what I call goals of care. And if you're ever in a hospital setting, when you have a palliative physician come up to you, they may use those words, goals of care. And it's terminology to basically say, is what you're wanting the goals of our care today to be about, is about to cure, to prolong life, or to focus on comfort. So we never want a physician to say there's nothing more we can do. That's the most infuriating thing I can ever imagine. But we do want our physician to say, we can't cure this treatment without having a ventilator or intubating, or eventually death is going to happen. Do you want to provide things that can provide comfort at this point? And that's when the goals of care, if they are about providing comfort, that's where the discussion of palliative care or hospice care is really appropriate, because those kind of professionals can provide care for you in a time where you don't want to be in any pain. And people don't always remember this, but air hunger is pain. Psychological grief is pain. So providing some support for that, I think, is really, really important. So again, those are really difficult conversations to have, but I think moments are what happen every moment. And every moment you talk to your loved one about these things is one less moment that you can worry about what's going to happen when. Many families, by the time they call and say, can we talk about hospice, will be so fearful because they've been putting it off, and it feels almost like a failure. And what I want to try to remind you is talking about this and having this kind of treatment isn't a failure. It's about making a choice about the last time you have in your life, whether it's 1 day, 6 days, 2 months, 2 years. It's about you being in charge of the wishes that you want. and doing the best you can. So I so appreciate you letting me talk about these. They're really, really hard conversations to have. So let's go have lunch.
Rebecca, thank you. Yeah, this has been it's so informative, and I love your candor. I think when we have these conversations, you can't tiptoe around things because people are thinking what they may not be saying. And so for those of you that didn't get a chance to put anything in the questions, you still can in the chat box. Or if you have any questions, or you can reach out later. You can reach out to our ALS Texas team, or if you want to reach out to Rebecca, we can connect you to her if you're in the Houston area. If you're in another area of the state and are attending an ALS clinic, there's social workers at those clinics as well. But you've got people throughout the state that are here to help you.
Absolutely. You know, and Tanya, sometimes people will say to me, well, why didn't the doctor bring this up? And I think the doctors are doing a better job at it. But many times when we're first talking to you about a diagnosis of ALS, we want to sustain hope because we don't know whether it's going to be a short-term or long-term. As you know, ALS is unique and individual, and some people live years and years and years. And so talking about the end of life can be really difficult for some physicians because they feel like they're taking away your hope. But at the same time, I think having information is power. So I hope this has empowered you also when you go to see your doc the next time. If it's a conversation you want to have, bring it up, because many times physicians will say to me, when I get uncomfortable about a conversation, I go into physician speak and I go, what's that? And they go, well, we use all kind of scientific stuff. Like we'll tell you about your breathing and your stats and everything like that. But I think if you say, doc, I really want you to talk to me about what does this mean and is it time, you know. And I think the good neurologist and the good pulmonologist will have the conversation, especially when they see that your breathing is decreasing. If you're having other symptoms that are bringing your ALS to a different level of treatment, because we do feel like you deserve information in order to make a choice.
Thank you, Rebecca. Again, and if you could send that form, I will make sure and attach that in the follow-up email that you all will get. Again, we've recorded today's presentation and we'll send that link to the recording to you later this week. And I think by having this recording, again, there's some days we're more ready to talk about these conversations than others. And even looking on this call today, I know some of you are living with ALS. I recognize some of you as caring for your loved one who's living with ALS. And each of you may be at different points in readiness to have these conversations. I think having a link to go back to when either of you are ready is so helpful to say, okay, this is going to help us have this conversation, or to go back to. So this is an ongoing resource that you can go back to anytime.
Can I mention one more thing, Tanya?
Absolutely.
What I was kind of being facetious when I go, this is difficult, let's go have lunch. But I really feel strongly that you've given yourself permission to have this difficult conversation, or listen to me talking about this topic. And I do think it's important when you get off this call to do something that will really help you kind of with your grief, because it brings it up to the surface. And this has been a really difficult week already, with the mass shootings in our country, with the Ukraine war, with all the things going on. And then it's come into this place. So I think if there's something that you can do to settle yourself, maybe it's having a bowl of ice cream, maybe it's going for a walk, maybe it's listening to some good music, maybe it's just getting some fresh air. Do something, because again, you need to balance in order for us to have that wellness that we talk about having.
That's so true. It's so true. And these are conversations that all of us need to have. As Rebecca said and shared, tomorrow is not promised. We know that for all of us, and having the conversations can bring peace too. I just had this conversation with my mom yesterday while we were over at her house as a family, spending time by the pool. We had a cookout. I didn't even plan it. It somehow came up in conversation, but she's not sick that I'm aware of at this time. But I wanted to know. And she said, you know what? We had a couple of tears. I'm not going to pretend that it was all just, fun. But she said, I'm really glad we had this conversation. I have peace that you know what I want.
Oh, that's so cool.
And I think that's really, really important. And again, if you didn't, if you're like me, I think of questions 10 minutes after the fact, and that's okay. So if questions come up for you later, reach out to me. I can help connect you to Rebecca. We can make sure we get you connected to the person that has the absolute best answer for you. And you can do that at any time. It's not just today or for this presentation. All right. Thank you, Rebecca. We so appreciate you, and we hope to see you again soon. Thank you all that joined us today, and we will get this recording out to you later this week. Okay.
Shout out to Marshall Nelson.
I know, I see him on there.
Rebecca, thanks so much.
All right. You have a good day, guys.
All right. Goodbye, everybody.
Bye.